Hi students, this is your instructor Diane Pizzacreta, and we are moving on to our next module, which is going to be on anxiety disorders. So we all start off with our learning objectives, and as I've said before, by this point you should have read your chapter and be ready to actively listen and take notes on the slides. So our learning objectives help us to organize our learning and tell us what it is that we need to be able to master by the end of the lesson. And so some things that we're going to be reviewing in this lecture are describing the clinical features of anxiety disorders, that you should be able to describe how anxiety disorders tend to co-occur with each other. In other words, that we see a fairly high level of comorbidity between anxiety disorders, that we gain an understanding of how gender and culture influence the prevalence of anxiety disorders, and that we're able to recognize commonalities in etiology across the anxiety disorders. I'm going to spend some time on this, talking about some of the different causalities of anxiety disorders. So one of the things that I do want to tease apart for us is that there is a difference between anxiety versus fear. When I'm talking about anxiety, we're really talking about apprehension about a future threat, with a level of worry or concern about something that might happen. This is really different from fear. Fear is really a response to an immediate threat. Both of them involve physiological arousal. Both of them involve the sympathetic nervous system kicking in. In other words, they're both triggering that fight or flight response, and they both can be adaptive. It could save your life. Something threatening pops up, and that sympathetic nervous system kicks in, your fight or flight response system goes at it, and you run away, you fight, or whatever it is that you do. This is the same thing with being able to anticipate something that might happen, and being able to prepare for that, or being able to think through how you're going to avoid those things. That can increase our survivability. So there is a certain level of adaptiveness that comes with fear, and also by extension with anxiety. But the thing about anxiety is that if the anxiety levels are too high, they can become detrimental. And this is the work of Yerkes and Dodson. And some of you may remember this from your Gen Psych course. I certainly review this when it comes to talking about motivation. What we see when it comes to anxiety is really a U-shaped curve. If you're engaging in a task and there's no anxiety whatsoever, it can interfere with your performance. In other words, there's no motivation there to get it done. You become lax, so to speak. And the converse is also true. If your anxiety levels are too high, that can also be detrimental to performance. Anybody that has test anxiety knows this. If your anxiety is just too high, you simply cannot perform. But it's really these moderate levels of anxiety that help improve performance. There's been a lot of research done on this, study after study, that talks about a little bit of anxiety during clinical research seems to help subjects perform and do better. What we're going to be talking about during this lecture are those extreme levels of anxiety, those ones that interfere with performance and interfere with our lives. And anxiety disorders, they are a category within the DSM, and there are several anxiety disorders that we're going to be discussing during the course of this lecture. We're going to be talking about specific phobias, social anxiety disorder, panic disorder, agoraphobia, and then at the end we'll talk some about generalized anxiety disorder. It is a very typical psychiatric disorder. When we look at a large-scale study of about 8,000 participants, we find that about 1 out of 3, 28%, report anxiety symptoms. People struggle. There are several people that struggle with anxiety disorders. It is not uncommon. And for those of you that are thinking about clinical work, anxiety disorders and mood disorders are going to be some of the most common things that you're going to be seeing your clients coming in with. Of all the anxiety disorders, the most common are phobias. That's the most typical anxiety disorder that we have a tendency to see. So this table here presents for us the percentage of people who meet the diagnostic criteria for anxiety disorders. When we look at specific phobias in a 12-month time period, we see about 10% of people. In terms of a lifetime, about almost 14%. Social anxiety has a tendency to be the next common, and so on and so forth. So what are some of the diagnostic criteria for meeting an anxiety disorder? The DSM sets out the criteria for us, and we're going to review that right now. The symptoms need to interfere with important aspects of functioning, or they need to cause a marked distress. In other words, the person needs to be reporting that they feel very distressed about the levels of anxiety that they have. They're not caused by a drug or a medical condition. They have to persist for at least 6 months, or at least 1 month for a panic disorder. And the anxieties, the fears and anxieties are distinct from another anxiety disorder. And we're going to talk about this in a little bit more detail, that comorbidity between anxiety disorders. So when I use that term phobias, what am I talking about? I'm talking about a disruptive fear of a particular object or situation. That the fear is way out of proportion to the actual threat. And there is a certain level of awareness that that fear is excessive, that it is higher than what it should be or needs to be. To be diagnosed with a phobia, the anxiety must be severe enough to cause distress or interfere with that individual's life. With a specific phobia, we're really talking about a disproportionate fear of a particular object or situation. Some very common examples include fear of flying, snakes, heights, etc. And the fear is way out of proportion to the actual threat. When we think about specific phobias, the most common have a tendency to be snakes, spiders are the two most common. Heights are also very common in claustrophobia, or fear of closed-in spaces. That the client has an awareness that the fear is excessive. In other words, they go way out of their way to avoid having any sort of contact. And most specific phobias do cluster around a few feared objects or situations. They have a tendency to be very focused. And this is important because you don't want to get it confused with generalized anxiety disorder. We do see a pretty high comorbidity of specific phobias. In other words, they have a tendency to go hand in hand with each other. So we do see this marked and disproportionate fear that's being consistently triggered by a specific object. For example, it's being consistently triggered by fear of seeing a spider, the anticipation that one might see a spider, or if one sees a spider, having a very excessive reaction to it. The object of the situation is avoided, or else it's going to be endured with a lot of anxiety, very intense anxiety. Again, it has to persist for at least 6 months to be able to be diagnosed as a specific phobia. In this table, we're looking at some different types of specific phobias. Snakes, insects, particularly spiders, things that are happening in the natural environment, things like storms, heights, water. All these generally start during childhood. One of the things I want to point out to you is that it is easier to develop a phobia towards snakes or spiders or heights than it is to, say, develop a phobia towards books. And the reason for that is a phenomenon called biological preparedness. And basically what biological preparedness suggests is that we are hardwired to be afraid of certain things or to be wary of certain things. Things like snakes and spiders and storms, and the reason is because those things can cause us harm. Having a biological preparedness to be wary of those things increases our survivability. So from an evolutionary perspective, it's sound to have this fear. And in fact, what's so interesting is that even very small children that are under 12 months, can recognize the shape of a snake and have a very strong negative reaction to that, understanding that's not something that they want to touch or something that they want to get near. And in this way, that's why we see these sorts of phobias being so much more common. Now, it's not as if you can't develop other sorts of phobias. things like anything from public transportation to books to being afraid of contracting an illness. Those things, certainly you can develop phobias to those too. There is a learning element that is involved in developing some phobias, and we're going to talk about that in more detail. But what I want you to understand is that it's just simply much more common to see phobias that are focused in on things like snakes, spiders, and heights. Social anxiety disorder, previously called social phobia, it was considered a subset of phobia, so there were specific phobias and social phobias. With the change in the DSM and then the DSM-5, it has now been separated out and teased apart from that, and now it's called social anxiety disorder. It's no longer called a social phobia. It has been set apart as its own diagnosis because psychologists and psychiatrists were finding that individuals that are stressed and anxious about social situations, those things seem to cause a lot more life disruption than other phobias. It is more intense and extensive than shyness. This is different than shyness. This is different than introversion. So this is not just the person who thinks it's hard to talk to new people, or the person that prefers to spend time alone rather than in the company of others. It is a persistent, intense fear and avoidance of social situations. The root of social anxiety disorder is generally always fear of negative evaluation or scrutiny. When you talk to a client that has a social anxiety disorder, ultimately what they get around to saying is, I'm afraid they're going to think something negative about me. I'm afraid they're going to evaluate me negatively. Exposure to the trigger leads to anxiety about being humiliated or embarrassed socially. We often see this onset in adolescence. If left untreated, what we see is about 33% ultimately become diagnosed with avoidant personality disorder. In other words, they become adults, they grow into adults that simply avoid social situations, completely avoid social situations. So what are some of the DSM criteria for social anxiety disorder? It is a disproportionate fear triggered by exposure to potential social scrutiny. Exposure to the trigger leads to intense anxiety about being evaluated negatively. The situations are avoided or they're endured with intense anxiety. And again, symptoms have to persist for at least 6 months. Remember, when we look at anxiety disorders, we're really looking at something that persists for about 6 months. What are some very typical examples of social anxiety disorder? The most typical are things like public speaking, eating in front of others, having to go into social situations with people that you don't know. All those things can become triggers that lead to intense anxiety. For some people, public speaking is so terrifying that they will choose a life path in order to avoid having to do that. What's very interesting about people that struggle with this disorder is that often they're very capable, but they work at a level below their capabilities in order to have to avoid these sorts of triggers. I remember, and I hear this often from students because I do teach ground courses. I often have 85 to 120 students in a course, and I lecture. And students will say to me, I don't know how you do that, or I'm not sure how you can do that. And I remember I had a student once who, what I have a tendency to do in my face-to-face courses is to ask questions. And I get to know students via seating chart, and I will call on them by name. And so I called on a particular young man. I'd asked him a question, and I could see he was struggling to answer, and then finally just said, I can't answer the question. And I said, okay. And I said, we'll call on somebody else who can help him out, and we continue to move on. I knew he knew the answer because he had gotten an A on the exam. I knew that he was a good student. He came down to speak to me afterwards and said, I have social anxiety. I'm very anxious speaking in front of a large group, and I would rather that you not call on me in front of everyone. And I said to him, after I called on you and I saw you struggle with the question, I knew that you knew the answer, but that you were having a struggle. And this is the very reason why I call on you, because you have to get it addressed. And I said to him, if you decide that you want to get this addressed, I can give you some referrals. And so a couple weeks went by, and he came to see me in my office, and I gave him a referral to a behavioral therapist. And I told him, do not let this continue on. I said, he was 19. I said, you're a young man. You want to be a physical therapist. I said, you want to get your doctorate in physical therapy. That is a high ambition. I said, you are a good student. I think that you can achieve that, but this is going to slow you down. And what was so interesting is that I checked in with him later on that semester. He did follow up on my referral. He was going. And at the end of the semester, he did say to me, I'm continuing on, and I feel like I'm making some progress. And I said, that's excellent. And then I lost contact with him, and years went by. And then I got an email from him, and he said to me, I just wanted to let you know that I presented my research for my doctorate in physical therapy at a conference. There was about 100 people, and I didn't have any problems with the presentation. And I want to thank you so much for forcing me to answer questions in your class and recommending someone to talk to. So I share the story because if you see yourself in any of these, anxiety disorders are very treatable, and we're going to talk about that at the end. But the sooner you get treatment, the better you get it. And the longer you wait, the worse that it gets. We're going to move on now to panic disorder. Panic disorder basically are frequent panic attacks that are unrelated to any specific situation. When I say panic attack, I'm talking about a sudden, intense episode of apprehension, the sort of feeling of impending doom. They peak out in about 10 minutes. It may feel to the person like they last forever, but in fact they don't. That's just simply how they're perceiving it. Physical symptoms include things like labored breathing, heart palpitations, chest pain, dizzy, sweating, lightheaded. Often people will say that they lose peripheral vision. They feel like they're going to faint. Usually what happens is people say, I feel like I am dying. I feel like I'm dying. They have feelings of depersonalization. That means it feels like they've left their body and they're observing themselves from outside. Sometimes they have feelings of derealization. That means like nothing seems real to them. And they will say it feels like you're going crazy or that you're dying, essentially. Panic attacks are not uncommon. About 1 out of 4 people, that's 25% of people, do experience a single panic attack. This is not the same as panic disorder. When I use that term panic disorder, I'm really talking about frequent panic attacks. It cannot be a single isolated incident. That does happen. It can happen to a person to have a single episode of a panic attack. Often with panic disorder, these panic attacks, we call them uncued. In other words, they occur unexpectedly. There's no warning. There isn't any particular trigger in the environment. This helps us to distinguish it from a specific phobia or from social anxiety disorder because there doesn't seem to really be anything going on in the environment. They are recurrent. And ultimately what happens is that the individual starts to become apprehensive and worry about future attacks. If we see cued panic attacks, in other words, it's triggered by something specific, we are more likely as clinicians to link that back up to a specific phobia. In other words, if a person sees a snake and they have a panic attack, that's a specific phobia. That is not panic disorder. So what can happen with panic disorder is that a person has these panic attacks. They start to become recurrent. The person starts to develop apprehension. Remember, one of the keys to anxiety disorders is the worry or the apprehension that something might happen. And the person begins to fear that they may have a panic attack in a public space, and they start to develop what we call agoraphobia. Agoraphobia is from the Greek word agora, for marketplace or open space. And the person develops anxiety about having an inability to flee anxiety-provoking situations, things like crowds, the mall, being on a train, being on a bus, and starts to cause significant impairment. The person starts to become worried. What if this happens to me when I am out and about in public? What am I going to do? And what happens is the person starts to limit where they go and what they do. They start to sort of create a circle that becomes smaller and smaller. Now, I want to point out here, agoraphobia was, in the DSM-4, it was a subtype of panic disorder. But about half of agoraphobics don't necessarily suffer panic attacks. Now, one reason why that might be is that ultimately agoraphobics will limit themselves, continue to limit themselves geographically to where they may get to a point where they do not leave their property, or they do not leave their own home, or maybe they might not even leave a couple of rooms within their own home. So now they're in complete control of a very, very sort of small area. And that may be one reason why we don't see the panic attacks, because there's nothing really left to panic about since you're not encountering anything that you might be out of control over. For the DSM-5, the criteria that has to be met for agoraphobia is a disproportionate and marked fear or anxiety, at least 2 situations where it would be difficult to escape or receive help. These situations might include going out to the mall, going out to a grocery store, riding a train, public transportation, those sorts of things. The situations are going to consistently provoke fear or anxiety, and they are avoided, or they require the presence of a companion. In other words, someone that person trusts, that they can travel with and help them to endure the intense fear or anxiety. Again, we have that marker, that time marker of at least 6 months in order to be diagnosed. Okay, we're going to move on now to generalized anxiety disorder. GAD, also known as GAD, and generalized anxiety disorder really involves a chronic, excessive, generalized, uncontrolled worry. It lasts about at least 6 months, and it interferes with daily life. People that struggle with generalized anxiety disorder, they're going to describe symptoms such as being restless, having poor concentration, being irritable. But often what happens is they can't decide on any sort of solution or course of action. Everything seems overwhelming. It becomes very difficult to make a decision, and so they're often stuck. That would be a word that would be typically used. Well, I just feel stuck. They worry about everything, and there's no one specific thing that causes them their worry, but they're worried about everything generally, things like relationships and health and finances, daily hassles. All these sort of things kind of accumulate and create GAD. We see this sort of behavior generally in adolescence. It begins in adolescence, and then it progresses as that individual grows into adulthood. So what are some of the criteria for generalized anxiety disorder? Excessive anxiety and worry, at least 50% of days, and about 2 life domains, family, health, finances, etc. The person finds it very hard to control the worry, sustained for at least 3 months. And the anxiety and worry are associated with at least 3 of the following. We just need to see 1 in children: feeling restless or keyed up, being easily fatigued, difficulty concentrating, irritability, muscle tension, and sleep disturbance. So this anxiety and worry, they're connected with avoiding situations in which negative outcomes could occur. A lot of effort and time preparing for situations that might have a negative outcome. Lots of procrastination. It's very typical in people that have GAD. They put things off and put things off, put things off. And that really in the end adds to the anxiety. They have difficulty making decisions due to all their worries. And they seek out a lot of reassurance. So what's interesting about anxiety disorders, we see a fairly high level of comorbidity. About 50% of those with anxiety disorders meet criteria for another anxiety disorder. So in other words, if a person gets diagnosed with an anxiety disorder, there's about a 50% chance that they will meet the criteria for another anxiety disorder. And then 75% of those with anxiety disorder then meet the criteria for another psychological disorder. We see a lot of comorbidity with anxiety disorders and depression. They do have a tendency to go hand in hand. We see substance abuse, that's not atypical. Personality disorders, also not unusual. And then other medical disorders, such as coronary heart disease. Are there any gender or social cultural factors that factor in? We do know that women are twice as likely as men to have anxiety disorders. So why is it that women seem to be prone to this? Well, the most likely explanation is that women are just more likely to report symptoms. Men, when we take a perspective, a gendered perspective on personality development, we know that men are supposed to be strong and problem solvers and deal with their problems and not admit weakness. And so it seems to go against their gender to be able to admit to a physician or be able to admit to a clinician that they're having this sort of excessive worry or an irrational fear of spiders. And women just seem to be much more likely to report these symptoms. If we look at it from a more of a developmental perspective, men are just much more encouraged to face their fears. If we think about how we raise boys, we just have a much higher tendency to say, you need to kind of get in there, you need to get it resolved, you need to face the fear, face it down, be tough, and so on and so forth. Women are more likely to experience childhood sexual abuse. One of the things that's interesting about this relationship between sexual abuse and anxiety disorders and depression later on in adulthood is that when children experience sexual abuse, they are put into situations where they have a lack of control, especially if that abuse is recurrent. They know that the abuse is going to happen, but they don't know when. And then we see that later on they carry that fear, that anxiety, that fear of being out of control into adulthood. As a side note, we also see higher levels of anxiety disorder in individuals, in children that face physical abuse, and also in children that grow up in homes where parents abuse drugs and alcohol, because they know that those outbursts are coming, but they don't know when. From a biological perspective, we know that women show more biological stress reactivity. In other words, they're much more sensitive to the environment. They react more strongly to that environment. That might be biologically adaptive. In other words, because women have had a tendency to take on the responsibility of child rearing, it is good from an evolutionary perspective to be more sensitive to any changes in the environment in order to take care of your children. And so we do know that women biologically or physiologically seem to be much more reactive to stress. Do we see any cultural factors? What's interesting about anxiety disorders from a cultural perspective is that we do know that anxiety disorders cut across cultures. We see them in all different sorts of cultures. But the rates of anxiety disorders do vary by culture, and the culture that a person is in can really shape the anxieties and the fears that that person might have. So some very culturally specific syndromes that we've seen are things like koyofusho, which is this Japanese fear of offending or embarrassing others, because that's very ingrained in the culture to be polite. Some individuals are, if they are possibly predisposed to developing an anxiety disorder, would manifest it in this way. Kayak angst, it's an Inuit disorder, and we see seal hunters, when they are at sea, particularly if they are alone in a kayak, they panic. Again, it's a situation that's very specific to that culture, and that's not something that we would see in our own culture, but it's one way that an anxiety disorder can manifest itself.